We're back here on the Lynne Hayes Freeland Show. So our subject today is one that a lot of people aren't as familiar with as we probably need to be, but I think you'll be glad that you tuned in. The other thing that just kind of hit me in the commercial break is this is a subject, and we've got three women talking about it, which I just think is awesome. Dr. Cherie Livingston is the chair of the OBGYN department at UPMC Littitz. Venice Lawrence is a certified nurse midwife, as well as a certified nurse practitioner. This is the last time I'm introducing you all with all your titles, just so you know. And Jessica Johnson is the director of surgical and anesthesia services, as well as chair of inclusion and diversity initiatives at UPMC Magee Women's Hospital. Glad to have you all with us. And Dr. Livingston, I'm going to circle back around to you because when we talk about women and poor outcomes, poor maternal outcomes, it reminds me that as we went into discussions about COVID and the coronavirus, and all of a sudden the world became aware of the fact that there were health conditions in our community or health needs that were going unmet, I feel like this becomes part of that discussion as well. This has been an issue that has been unmet until recently.
There is a historical premise to this. When I think of health disparities and why there's such a difference, and when we talk about difference, from 2011 to 2013, the CDC noted that for every 100,000 live births, 13 white women died, as compared to 44 Black women. So that's 44 per 100,000 compared to 13 per 100,000. That's CDC data, and that's not 100 years ago. That's from 2011 to 2013. That should gain all of our attention. And fortunately, we are seeing people pay more attention. So when I dissect that data, what I say is why? And I think of 4 specific reasons why. And my colleagues on the call tonight have eloquently delineated that. 1, systemic racism. 2, historic inequities. 3, current inequities. And then 4, social determinants of health, which we discussed. But when you think about historic inequities, everyone talks about Tuskegee, but we can go lots further back. Mm-hmm. When we think about the surgeries that were performed on Black slaves so that Dr. Sims, a gynecologist who's very well known in our country, could practice surgical techniques. You know, we have to think of Anarcha. We have to think of Betsy and Lucy, who were Lucy actually, I think it was Anarcha actually, who had 30 procedures performed on her without anesthesia. So there's a historic legacy, unfortunately. Mm-hmm. And so when you talk about a patient coming to the office to see me or Venice, and they want to discuss their pregnancy, no wonder there's hesitancy or distrust. Now, fortunately, we do have data that shows that pregnant women, actually all people of color, are more likely to adhere to their medical recommendations, come to their visits, if there's cultural congruence. And so that's why it's important that we fix the low rate of providers of color. Mm-hmm. That hasn't changed. That needle has not moved in 40 years. 5% of US physicians and surgeons are Black. 69.8% are white. That is not representative of the community when Blacks make up 12 to 13% of the population. Mm-hmm. So there are so many factors.
And Jessica, you know, we've done quite a few COVID-related shows working in cooperation with the Black Equity Coalition, Gateway Medical Society, and that's one of the things that they continually talk about is that pipeline that doesn't exist to get people of color involved in the medical community. How do we, tell me some of the things that we need, we as the society in general, UPMC, what do we do how do we fix it?
Well, here at UPMC in our partnership with University of Pittsburgh, we know that we're training a high number of diverse students that are coming here. So it's a combination, and it's also in partnership with our community, because then the problem becomes we need to retain that talent in our region. And so it's very key that we're having these conversations with our community alliances and how we're keeping this talent here in our region, and making it comfortable for middle class Blacks and to live in the Pittsburgh region. And so we know that's one factor. We know that we need to be intentional to have representation. And so we are partnering with our nursing schools to create that pipeline. And we're really excited about the future in the next few years to have a steady pipeline of diverse nursing students, because they're one of our best advocates at the bedside for our patients. And so we know that that's one combination. So we're hitting at all levels, from residencies to have pipelines for our physicians. But I will also just make sure and put that plug in there that as a community, we need to partner with you to make sure that if we're training talent here, we need your help to keep them here as well.
To keep them here, yeah. And you know what? Sometimes, just as you were saying that, I was thinking, man, this is an election year. These are some of the things that, at least here in Pittsburgh, the mayoral candidates need to be talking about. But that's a conversation for another day. Venice, I'm going to come to you and say the same thing. I mean, I mentioned to you before we started the show that both of my grandchildren were delivered by with a midwife that looks like you. But they're in Atlanta, Georgia. You know, people don't necessarily think about those kind of things in Pittsburgh. You're in Williamsport, Pennsylvania. Yes. But it does. I mean, for certain things, and I even think in terms of my own show, I know there's certain subjects that if I don't have somebody who looks like us talking about it, my viewers aren't going to pay attention. You know, there's just certain things that you got to see somebody who looks like you to believe it.
I agree with that. Especially, I get a lot of young patients, and they would request to see me all the time. I love doing that because I love to sit and talk to them. I love to talk about the risk factors that place them at higher risk for comorbidities and mortality. We're talking about low birth weight and premature labor, diabetes. I spend quality time talking to them about these issues, and they sit and they listen. And when they come back the following visit, they explain to me that they tried this and they tried that. And it feels really good as a provider to know that I'm able to make that even a minute difference in someone's life that could potentially save them down the line. It's very important for us to, as Jessica said before, to figure out a pipeline of how to get providers who look just like us, that could represent us in healthcare, in pregnancy, where we're seeing these issues, the high mortality rates. So I think it's going to become, over the next couple of years, it's going to become more so to get women and get providers of color involved. And that will help the mortality rate. I believe it will, just based on the minute changes that I have seen in my years of being a midwife, that I could make the differences, and being the advocate for the patient, talking out for my patients, and educating them so that they make informed decisions, letting them know, because they will come and they will ask questions and they will say, well, such and such person said this, what do you think? And I offered them the information, unbiased information. And then it's up to them to make that decision.
You raised a couple points I want to pick up on. We got to get a commercial break in. We'll be back in just a minute. Don't go away.